Bajaj, please.
Thank you. Thank you to INASL for this wonderful conference and this exciting new method for us to prevent rather than actually only focus on treatment. So my topic is hepatic encephalopathy and some questions. Why do we need to prevent it? What means do we have to define who will develop HE? What about are we preventing the first episode or a subsequent episode? There are some special situations I'm going to talk about, and then treatment and prevention strategies. So why should we care about preventing encephalopathy? It's now the first decompensating event in mast cell cirrhosis. We know it independently increases mortality. It definitely increases morbidity and impairs daily function, and unfortunately is not prioritized for transplant even with MELD 3.0. It increases the caregiver burden, and it is the number one cause of preventable readmissions in the United States and most of the world. The important thing is the biomarkers that we can use for hepatic encephalopathy stem from the fact that it is a systemic disorder. Even though it is termed hepatic encephalopathy, it affects the gut, it of course affects the liver, it affects the kidneys, it affects the skeletal muscle, and ultimately the manifestation is in the brain. Unfortunately, some of those manifestations that we think about are changing and have relatively poor sensitivity or specificity. What are the factors that are actually increasing the incidence of HEs on the left-hand side? Diabetes, obesity, CKD, an aging population, comorbid brain diseases, polypharmacy, sarcopenia, and rising alcohol consumption. So not only do they predispose patients to get hepatic encephalopathy, they also predispose people to get other conditions that could either be mistaken for hepatic encephalopathy or could actually make the pure progression of hepatic encephalopathy prediction a little bit difficult. So our patient population is clearly not the same that we had even 10 years ago and definitely not 20 years ago. This is a nice culmination of a lot of things that can put together. On top are the cognitive tests in green. Then you have blood tests such as IL-6 and ammonia. Then you have things such as spontaneous shunts, gut microbiome, sarcopenia, and composite scores like this, all of which have had some parts in predicting who will develop hepatic encephalopathy. The green are those that have initially started in one group and has been validated elsewhere. The yellows are the ones that have no external validation. And the mixed cohort means that the group included people who had had prior hepatic encephalopathy versus people who did not have hepatic encephalopathy. So therefore, the combination was of recurrence versus the first occurrence, whereas the green included people separately with prior hepatic encephalopathy and those without prior hepatic encephalopathy. So let's talk about what to do in the outpatient setting versus the inpatient setting. So there are several ways we can approach this. The outpatient setting is a little more messy because people can do their own things and we may not know what's going on, but this thankfully is the majority of our patients. The majority of testing that have been done are cognitive tests. Some blood tests have been used, some radiological features, and there is also an intriguing genetic risk factor for hepatic encephalopathy prediction. There are some population-based scores such as the bilirubin, albumin, and beta blocker statin, with the high bilirubin, low albumin, which is reflective of bad liver function, beta blockers, which at that time were reflective of advanced portal hypertension or portal hypertension that required more therapy, and statins were less progressive. So what they found is the baseline model of this showed that the annual risk of hepatic encephalopathy increased, and even in the Kaplan-Meier curve, you can see the high risk, this is the proportion free of hepatic encephalopathy, is the lowest with the people with a high score of this. So in a population like a FIB4, etc., if you want to look at who will develop all of this, this might be good. But this may not be good for the individual patient that you want to actually think about. And things that we can do in practice is animal naming test, which in 1 minute you can name as many animals as the patient can write. And if it's more than 15, it gives you a crude way of knowing that this patient has covert hepatic encephalopathy this time or not. The problem is, remember we talked about the aging population. This came from the dementia literature. So if someone does badly on this and is also relatively old or has risk factors for both dementia and hepatic encephalopathy, you would not be able to use this. But suffice it to say, if someone does badly on this, it gives you an instruction that there is something wrong that needs to be investigated. And initially, that's the only thing you need, a test with a high inclusion value at this page to go further. What about Stroop? The Stroop test that we had developed takes around 5 to 10 minutes. While it seems like a small amount of time, if you add it across multiple patients, it takes a lot of time to do this. So we came up with an even smaller test called the quick stroop, which is 1 minute. And this 1 minute, we found that this actually diagnosed CHE with a similar accuracy as if the entire stroop was done, which can take up to 10 minutes. Moreover, this was able to tell us who actually develops covert hepatic encephalopathy, who doesn't develop covert hepatic encephalopathy. So this is something that could potentially be used into practice, and because it's the off stage, it is not language dependent. The on stage requires you to know what language this is presented in. The off stage does not. It just tells you what the color is. What about ammonia levels? If there's anything more contentious in hepatology, please let me know. That is it. But I'm not a strong believer in ammonia levels, but many people in this room and in the world are. So I'm going to be as neutral as possible. This is a useless test. Sorry, not neutral. It is a test that has to be taken into consideration. You can't do it blindly. You have to know whether the patient is fed or not. You have to not put a tourniquet. When is the last time you actually drew blood without drawing a tourniquet? All of these things increase the ammonia levels. If you send the ammonia levels to 8 different labs, they'll have 8 different, widely different answers. So what you want to do is to only use ammonia levels very sparingly. If a patient is confused and you have no idea why they're confused, a high ammonia level will tell you that this is actually related to hepatic encephalopathy. If a patient is confused, but the ammonia level is low or normal, it has a good exclusionary value for this. That having been said, it has prognostic capability in populations. It may not be individualized in those patients. So it is important, but there are always caveats. So before you actually put all your eggs in the ammonia basket, make sure that you actually interpret it so that it actually doesn't add to the confusion, your confusion. Let's talk about oral glutamine. This is a very elegant test and very simple test to do. And this really does, and as told you, ammonia per se, one time is a problem. But with oral glutamine test, if you give someone 20 grams of protein and their ammonia level rises, when in some people it doesn't rise at all, that tells you this person is going to have a bad outcome, those whose ammonia level rises in response to a protein. Now we went one step further. We gave them a meal. The meal came in vegan, vegetarian, or meat. And what we found, the ammonia levels only increased with the meat intake. If you gave someone a meat, 20 grams of a burger and nothing else, versus gave them a 20-gram vegan burger or a vegetarian burger, you can see in the red, only the meat ammonia levels went up. So it is important, so if there are some people who can reduce their meat intake, if they have hepatic encephalopathy, you can substitute it, and this is important, do not restrict the protein. You can substitute it with an equal amount of vegan or vegetarian protein, which could potentially reduce their ammonia levels. Now this was done in a very small study, so we want to replicate it across larger studies, and especially in the Indian context as well. What about the presence of spontaneous portosystemic shunts? We know this is very important in patients who have recurrent hepatic encephalopathy. In people who have a recurrent hepatic encephalopathy, clearly we want to look at this. But there has been nice and exciting studies in which patients with higher spontaneous SPSS have more HE, and especially in people with MELD 629 or Child-Pugh A, this was associated with more complications and mortality. This is not shocking, since these patients, this is reflective of more portal hypertension. But clearly the important here is that this is another prognostic capability of patients who have never had hepatic encephalopathy before. Then they can have hepatic encephalopathy occurrence if they have a lot of these shunts. But currently the action is only taken for recurrent hepatic encephalopathy because unfortunately none of these have come up with a cutoff. Area like this means this patient is definitely going to develop HE versus not. But it tells you there's another way in which we can prognosticate these patients. Now to me this is the very exciting thing, and is done only in the Spanish population right now. Clearly other populations might be different. There are some things in the transglutaminase enzyme in the small bowel. Why is that important? Because you don't need to have any dietary protein, you don't need to have any bacteria to have ammonia in your system. If you take enough protein, the glutaminase enzyme will in your small bowel will actually break it down to glutamate and ammonia. And high ammonia multiple times could be association with hepatic encephalopathy. And what these people found in Spain, that there's very good correlation between genetic score variations and presence of hepatic encephalopathy with and without previous HE. So you may have specific SNPs that could actually predispose you to have hepatic encephalopathy. And if you find this, maybe these are the people you want to prioritize to give the vegan and vegetarian diets, or at least get more of those in their diets than possible. But there are many, many ways to actually predict who will develop their first or their subsequent hepatic encephalopathy episode. Then we come to the inpatient setting. Thankfully, not every patient that we see inpatient has hepatic encephalopathy. But why do we need to know whether someone is going to develop higher grades of hepatic encephalopathy? Part one, they may have developed aspiration. But the more important thing is not everyone is eligible for transplant. You want to know what their wishes are, their wishes, not their relatives' wishes. If you know in 2 days this patient is going to get comatose, you need to know all of that right now so that you can make a lot of planning decisions for that patient and for themselves as well. So what we found is in a large center group, multiple serum metabolites, but also thyroxine was able to predict who was going to develop grade 3 and 4 in 602 inpatients. And moreover, because the thyroxine is available in local laboratory, we were able to validate it in the local laboratory settings as well. And this was also replicated in an inpatient cohort from India. So there is a cutoff of thyroxine. If you're lower than that you are going to have a high chance of developing grade 3 or 4 hepatic encephalopathy. And these patients, as you know, were not being ignored. These are the leading centers across US and Canada. We did everything in our power to prevent grade 3 and 4 hepatic encephalopathy, but they still developed this just in case. The other things that are important is gut microbiome hepatic encephalopathy. What we were able to find is on admission, there were different encephalopathy gut microbiome features in those who develop hepatic encephalopathy, which includes a lot of the proteobacteria, which is gram-negative organisms, such as Enterobacteriaceae, and lower of the fusobacteria. And this was then replicated across a center in Taiwan. And this does differentiate between PTSD, dementia, and hepatic encephalopathy, and it is very different between HE and no MAG. Now, by no means I think this is a test that is ready to order, but this is something that also tells us there's good proof of concept. Not only is the thyroxine level, but also other things that are important in these patients. So what can we do for these patients? The first hepatic encephalopathy occurrence, unfortunately, all we can do right now is ensure etiology control. And that's important. Poor evidence basis for initiating therapy in multi-center trials. There is no evidence right now that even if someone has minimal hepatic encephalopathy, that giving them lactulose or giving them rifaximin is going to prevent their first episode of encephalopathy. Right now there is a multi-center trial called Red Sea happening across multiple centers in the US, including in India as well. Hopefully we'll get some answer because that's a new formulation of rifaximin. What about HE recurrence? You want to ensure precipitating factors are treated and patients and families are aware of symptoms. Medications such as lactulose and rifaximin must be initiated appropriately and the patient needs to be taking them. What about tips? Clearly, the risk of encephalopathy is higher in people who are older, prior overt HE, sarcopenic, advanced liver disease, and the benefit is higher in those the tips is urgent. So this study showed if you give them rifaximin, the rifaximin actually reduced the occurrence of post-TIPS hepatic encephalopathy in a large friend cohort. At least in the US that I'm aware of, majority of our patients are already on rifaximin in this stage when they're set for TIPS. So this really does not help us that much. The other thing is a lot of these patients actually were on lactulose before, which they withdrew quite controversially. So these people were unfortunately set up to have hepatic encephalopathy after TIPS placement. So that's a kind of a problem. What about in upper GI bleeding in inpatients? In this study that was also done in another study with Lola, lactulose, and rifaximin, in patients with upper GI bleeding, giving them lactulose prevented their first episode of inpatient hepatic encephalopathy. This can be used in your practice today, but make sure that you give lactulose. When you're giving lactulose to someone who's bleeding from their mouth, you give it as an enema, okay? And so, because otherwise you'll add to their aspiration risk and make things a lot worse for them. So again, to summarize, a lot of these tests are available, a lot of these tests are not available. So hepatic encephalopathy is a critically important event in the natural history of cirrhosis. Challenges in demography, etiology and comorbid conditions are a problem. Static tests in outpatients such as cognitive performance, ammonia and cross-sectional imaging have shown promise. Dynamic tests such as change in ammonia, especially after meat-based products, should help us further. Gut microbiome composition in products as well as serum thyroxine can classify who will develop worsening of HE. However, it is as yet unclear whether prevention of the first episode of HE can be achieved solely by prophylactic therapy. Thank you so much for your time.